Hey, hello everyone. Thanks for tuning in today. Welcome to our event on systemic racism and inequality in medicine. This is a student-led initiative by first and second year medical students at St. George's University School of Medicine. And we are here to shed light on a topic that is uncomfortable, but very necessary to talk about: racism. We as future physicians, as a collective, need to become vocal and willing to have conversations with our peers about things that matter. And it's been beautiful to see that happening in 2020 more than ever before. And people are starting to ask the question, why? And that question, why, is the way to make this country move forward. So identifying the issue, creating a plan, and then executing the plan. But the first step to be able to do this is to make us even aware that there is an issue. So we're hoping to do that today for our fellow classmates and medical colleagues. So today we're going to be speaking on current general statistics, historical background of the issue, health disparities that are present in cardiovascular diseases, and maternal and infant health. And collectively, we will be sharing a call to action as medical students and future physicians. This is an open discussion, and although we have our 7 speakers here today, we hope to have participation from everyone tuning in during this live event through the chat thread. And Anjali is going to be posting the link for our anonymous Google form. And we've been requested to keep the questions confidential. So if you can submit your questions through the Google form, because this is a sensitive topic, but any comments you have, feel free to plug them directly into the Zoom chat, and we can get a good conversation going. And so all of our questions that come in will be posted by our questions moderator, Anjali, and she'll be posting them into the Zoom chat thread, so you'll be able to see other people's questions as well. And we will answer as many of them as we can, and any questions that we don't address during the session, we'll have answers for you in the upcoming days. So before we get started on introducing our speakers and beginning this open discussion, I just want to take a moment to remind all of you to be respectful to each other. This is not intended to be a political debate. What's right is right, and we are on our way, most of us, on our way to becoming ethical and well-rounded physicians. And this is an innately sensitive topic, and we all have like a pretty political and racially diverse community at SGU, so it's really important to show respect for your colleagues and your peers. Also, this is our first event, and we hope to hold more of these in the future, so please excuse any glitches that occur. We're totally open to feedback. We actually would love your feedback so that we can improve upon how we deliver the message next time. So first, I'd like to begin by introducing our speakers. We have a very accomplished group of leaders here today. First, we have Ria Raj, who is a first-year medical student from Dubai and is president of the SGU chapter of Incision, which is an international organization that aims to provide safe and surgical anesthetic care in low-resource countries. And she has also recently published a commentary on systemic racism in healthcare in Kevin MD, which is a well-known platform for medical students and physicians. Next, we have Vaishnavi Singh, who is a second-year medical student and has 1 year of clinical research experience in surgical oncology at the University of Texas Southwestern, and has been a senior youth group leader for a nonprofit, Ananda Marga, an organization that does charity for low-income families in India. Next, we have Orsiola Arapi, who is a second-year medical student and has 4 years of clinical research experience where she led projects in writing research protocols and enrolling patients, onto trials at the Northwell Health Department of Neurosurgery in New York City. Most notably, she helped to develop a research program from the ground up for the spine outpatient office, which now has over a dozen clinical trials. My name is Radhika Tucker. I am currently a second-year medical student, and I have a master's in public health from the George Washington University and 3 years of clinical research experience in cutaneous oncology, pediatric oncology, and bone marrow transplants at the University of California, San Francisco. And now introducing our guest SNMA executive board members who are graciously sponsoring our event today. First, we have Conrad Irons Jr., who is a second-year medical student with a Master's of Science degree from Chatham University and has served as an adjunct professor at Bryant and Stratton College teaching anatomy and physiology, and is currently the treasurer of the SGU chapter of SNMA. Next, we have Chris Johnson, who is a second-year medical student with a BA in psychology from NYU and has also worked with the Association of Black Cardiologists to educate underserved communities in New York about cardiovascular disparities. Chris is currently the event coordinator of SNMA at SGU. And lastly, we have Janae O'Gwyn, who is a second-year medical student with a BS in psychology from Prairie View A&M University and a master's in public health from the University of Texas Health Science Center School of Public Health, and she is currently the vice president of SNMA. Okay, thank you so much to our viewers for tuning in today, and let's get this conversation started. Okay, so what is systemic racism? It is a reference to the systems that are currently in place that create and maintain racial inequality in nearly every facet of life for people of color and low socioeconomic status. Glenn Harris, the president of Race Forward, defines it as the complex interaction of culture, policy, and institutions that hold in place the outcomes that we see in our lives. Systemic racism.
Radhika, we can't hear you.
You still can't hear me?
No.
How about now?
I can hear you. I'm not sure if everyone else has the same issue.
I think just making sure that everyone else's mic is off, because it seems like there is a few mics that are on. Even if people are planning to speak later, I think if everyone shuts them off, it will cut out the feedback.
Okay. Does that work? Can you guys hear me? Yeah, okay. So systemic racism is synonymous with institutional racism or structural racism. But ultimately, they refer to racial issues that stem from the ground up. Medical racism specifically manifests itself in 4 different ways: conceptual ideas of race, racial discrimination resulting in differential medical treatment, the experience of racism negatively impacting one's health, and institutional racism. For hundreds of years, race was and is still a social category that allows for differential access to power and resources in society. Systemic discrimination is not just the behavior of a few, but often supported by institutional policies and unconscious biases based on negative stereotypes. Conrad, can't hear you.
Still can't hear you, Conrad.
Are you muted?
What about now?
Perfect.
Okay, good. I just wanted to say thank you for that intro, by the way. Radhika, I didn't get to say thank you before, but you're right about systemic racism, right? And our job now is going to be to talk about the statistics of it. And so when you look at health over the past 50 years, everybody's life expectancy has increased exponentially, right? We can see that. However, African Americans, we're still lagging. We're seen to have about 6 years less life expectancy compared to our white counterparts. and we have higher rates of comorbidities and mortality. So we know that things like preventative care, early intervention, management of chronic diseases plays an important role in determining someone's health. But Blacks and other minorities typically have lower levels of access to medical care in the US. We see this through underrepresentation and unemployment, high paying jobs, and then just that simple access to health insurance or other benefits that you might get from these jobs, right? So those things all play an important role, especially when you're talking about trying to have preventative care for somebody. So we also have seen that Black patients typically have to wait longer in the ER and primary care as compared to the white counterparts. Commonly, we can also see mistreatment in the community. We're gonna talk about this later, but just like in our curriculum, how sometimes they miss out things that may present itself differently in the African-American community when you look at things like skin and different things that could identify different diseases. When we speak on Black women, they even experience it further, because not only do you have that racial minority issue, but you also have that vulnerable gender demographic that you can see. And I think you have some stats on that you were telling me.
Yeah. So Black women are 22% more likely to die from heart disease than white women. And Black women are less likely to have breast cancer than white women, but are 40% more likely to die from breast cancer than white women are. Black women are also 71% more likely to die from cervical cancer than white women, and 243% more likely to die from pregnancy or childbirth related causes than a white woman, which we're going to address later in the maternal health section. And even among the current coronavirus pandemic, systemic racism is clear. Black Americans are dying at about 2.4 times the rate of white Americans from COVID. And this is happening in 2020. And it's frankly unacceptable that this kind of disparity has gone on for so long. And we as future physicians need to make a generational change to a brighter future that is inclusive of the entire human race. And also, through a lot of research that we've all done in the past few weeks, I've heard that health disparities have deeper roots that stem farther than just the medical system. And so it seems to me like racism is occurring in all fields and at a very systemic level, not just in medicine. And we've been seeing that clearly in current events.
Right. So, like you said, there's a lot of different things that contribute to health, right? So one's environment, social factors. You can see different things, even down to the zip code, that basically your environment and where you are plays an important role in your health. When you look at things like socioeconomic status. However, I found this out on MedPage today, that health disparities are greater between middle and upper class African Americans, even compared to middle and upper class whites. So this tells us that the correlation between socioeconomic status and health is actually dependent upon race. So in addition, we have the unfair treatment that strongly correlates to those higher mortality rates. Being oppressed for our skin color is a health problem, right? Not only is it a justice problem, and we can see the injustices that have happened politically, but like we said, also it's down to that healthcare aspect. So, the things that we encounter daily, the racism or the fear of racism, can be traumatic, even if it's underlyingly so, because not a lot of people might even identify with the trauma that they face. But there's a lot of things that happen on a daily basis that, can ultimately affect you, whether it be causing of chronic stress, mental health, anxiety, depression, or anything else like that. And because of these systemic issues in the country, you can even see that things like we have higher exposure to pollutants or cancer, asthma, heart attacks, high blood pressure. I mean, the list goes on. Additionally, we have a lack of access to healthy and nutritious foods oftentimes due to food deserts that might be occurring.
Yeah, so basically, in summary, we need to better our attempts at caring for the marginalized minority groups. And it's our job as future physicians to improve upon the treatment of the disadvantaged and identify the roots of systemic oppression to eliminate racial inequities in medical care. And these statistics that we just presented to you are why we have chosen to cover maternal health and chronic illnesses in our discussion today. And these two fields experience some of the most drastic health disparities in the US. And racism towards minorities is not a new concept here in the US.
No, not at all, right? I know some people who are African American. I mean, I even have a couple friends, but they'll tell you that their grandparents or their great grandparents typically don't trust the healthcare system, and there's reason for that. Statistics have seen that we have decades of oppression towards the Black community. I'm going to touch on this briefly, but in the mid-1900s, there were hundreds of impoverished African Americans that were used to observe the progression of untreated syphilis, and they were withheld the known standard treatment for syphilis just for the sake of observing the progression of the disease. This isn't right. We know that. So not only was care not provided when these people went blind, insane, or any other severe complications that come with syphilis, but it also had a trickle effect for decades as far as like the kids contracting it, you know, so congenital syphilis, or like the spouses also contracting it. And this went on for decades, and the physicians didn't take action, and they watched a marginalized population kind of wither before their eyes, so to speak. And this is only one example of the racial discrimination that we've come across in the healthcare system.
Yeah, and we're going to hear more about that when history is covered. We did get a really good question in about this topic. So what steps can we take to positively impact the health of minority groups and close the statistical gap of healthcare disparities? That's a great question. We're going to cover it. We're going to cover it a little bit right now. This will also get covered again in the call to action. But the first step, I think, is to diversify the career. And diversifying the career starts at the systemic level. Like diversifying, if you want to diversify the statistics, you have to also diversify the physicians and all the research staff and all the nurses. Everybody in the line has to be diverse in order for there to be any changes to the current statistics that are happening.
Right. Also, I would say for my answer to that question too would be mentorship programs, right? So a lot of the times there's kids that might not have a role model or somebody to look up to in that position that are even deciding to have a career in science, and they might not know of all the options available to them. This personally hits home for me because my aunt is a physician, right? And so I don't know where or how well I'd be off or how far I would have gotten without her help or her guidance throughout this whole time where I am today, right? So getting involved in the community, I feel like can have a big impact on our representation. Because I believe I saw a stat that was African Americans make up 13% of the population, right? We are only 6% of the healthcare field or make up physicians. Those numbers seem small, but if you look at it statistically, that means we have less than half of the representation that we should as physicians. So I think starting at the mentorship level and even helping these kids and showing them that there's options and there's people that look like you that can do what you're doing, I think that'll go a long way.
Yeah, I am going to cut us off there for statistics. Let's get into the history a little bit.
How's everybody doing? Thank you, Radhika, for that introduction. To all the viewers tuning in, thank you guys for tuning in. And We hope you guys are staying safe. We know there's a lot going on in the world, but continue to stay positive and keep your head up, and we hope for better days ahead. So basically, as Radhika said, I'm going to touch on a little bit of like the history of some of the systemic racism that's been going on in the healthcare system. Particularly, I'm going to be talking about social.
Please mute their microphones. Can everyone please mute their microphones?
Okay. Yeah. As I was saying, so I'm going to be touching on like the socioeconomic status as it relates to African Americans in healthcare, and kind of a little bit of like the historical background about, how the majority of, or how a lot of African Americans come from impoverished communities. And so I think we can all agree that socioeconomic status plays a really big role in healthcare. Those with a higher socioeconomic status tend to have better health in general than those with low socioeconomic status. And there's two perspectives that can be looked at. There's the social causation theory, which states that socioeconomic status is the key driver in racial inequality. And there's also the health selective theory, which is a theory that says that those who just have good health, it will lead to them having better socioeconomic status. And while there are debates going on between both theories, there's a relation between socioeconomic status and lifestyle. So those with a lower socioeconomic status tend to have, also a poor lifestyle, a lot of drinking, sedentary behavior, and things of that nature. And those with a higher socioeconomic status tend to have more of a, more of a healthy lifestyle, which is, spiritual health, mental health, physical health, exercising, and things of that nature. So where am I going with this? What does this all have to do with systemic inequality? So a lot of these low socioeconomic status communities are largely inhabited by African Americans. So, and a lot of people, the misconception is that, oh, like African Americans aren't working or yada, yada, like, but that's actually as a result of systemic racism. And I'm going to briefly touch on a process of the government known as redlining. So what this means, what redlining is basically just the restriction of services, of government services, right? Due to the color of somebody's skin. So back in 1934, during the Great Depression, the National Housing Act was passed. And this act was passed in order to basically stop houses from being foreclosed. But in the process, redlining, what redlining is basically just restricting loans from communities of color, because communities of color were seen as a poor credit risk. But that wasn't the only thing that was taken away from these people. Healthcare was also taken away from these people. Supermarkets were placed in very far away places just so people couldn't, get the resources that they needed. So when we talk about systemic racism, as Radhika defined earlier, it's a form of racism that's embedded within society as normal practice. And this is what the government was doing at the time. They were restricting services from these communities strictly because of the color of their skin. And so this stopped back in 1968 when the Fair Housing Act was passed. That was a part of the Civil Rights Act of 1968, right after Dr. King had died. But that was over 50 years ago. And we're still seeing today, what we call a racial wealth gap. And so what this has to do with healthcare is that there's little to no access to healthcare in these communities as a result of this redlining practice that the government was doing. And so a lot of people may say like, oh, diabetes, hypertension, and things of that nature, I guess African Americans are just subject to those diseases just because they're African American, when really it was due to, you know, unequal distribution of social, political, economic, and also environmental resources for decades. And so that's just a little bit of the historical background in terms of socioeconomic status and its relation to African Americans within these low socioeconomic status communities. And I think Vaishnavi was going to discuss another aspect, which is the mistrust in the healthcare system.
First of all, thank you everyone for tuning in. I'm going to take a little bit of what Chris was saying and what Conrad was saying. So when Conrad was talking about how African Americans now have a lower life expectancy, significantly lower than the other popularities, we see that, well, I know some may question, like, why don't they just go visit a doctor? Why is preventative care such, like, at such a why is it so downplayed? I would like to discuss a few moments in history which have deeply embedded mistrust that African Americans have against healthcare officials. I would like to start a little bit earlier in about the 19th century with the father of gynecology, which some of us may be familiar with, Dr. David Sims. So he operated on Black enslaved women without anesthesia to fix vesicovaginal fistulas that they had. The decision to not use anesthesia was based on the belief that Black people did not feel as much pain. And to this day, we see in the healthcare field that African Americans are denied pain medication at a much higher level than other people are. It's also unknown whether these enslaved women had consented to being operated on without anesthesia. It also arises the question whether their consent meant anything. Were they even allowed to say no? Another point in history that I would like to talk about is the Tuskegee experiment that Conrad started us off on. So it started about in 1932 when researchers wanted to see the effects of syphilis, and they chose a few hundred Black men who were primarily sharecroppers, and most of them had never even visited a doctor before. So what did they know about, like, what was happening to them? They were told that they were being treated for bad blood, which could basically have meant anything. It was just a term used to describe disease at the time, and they were promised free medical care, so that was it for them to sign up. Later on, it was discovered that penicillin was a common treatment. It was like the desired treatment for syphilis, yet the researchers wanted just to see how syphilis would carry out among these men, so they just let them go, and many of them died, went insane, went blind, and many even had children who then the mothers maternally passed down the syphilis to the kids. I think 40 or 50 years later in 1973, Congress did have this shut down and issued an apology and even offered a $10 million settlement. But at this point, it was almost too late. They just went through all of this, but what is money going to do to them? Another really big point in history was when a physician named Dr. Gay operated on Henrietta Lacks. So what he did was that he snipped cells from her cervix to basically grow her tumor cells. So for a long time, scientists were trying to grow like these tumor cells, and Henrietta Lacks were a little bit different because in 24 hours they were reproducing and they weren't dying, which is something that was like uncalled for at that time. So he, without her consent, without letting her know, he just took those cells and he created what is called the HeLa cell line, which to this day is used to study toxins, viruses, and was actually a very big help in the discovery of the polio vaccine. So Henrietta Lacks obviously didn't know about that this was happening to her, and her own family didn't know that this had been done to Henrietta until 20 years past her death. So I think these three big events, or which are among like so many, kind of describe the mistrust that African Americans have in healthcare officials. They don't know whether their best interest is in their mind, whether they're going to be taken seriously, and if anything is even going to be done if they like arise any questions.
I have a question right here. So we have common practices in medicine such as race corrections and spectrometer readings dating back to slavery in America, or white versus black GFR measurements. I hear so often, just put your head down and get the degree and get out. But what should we be doing to question facts we know may not be evidence-based while we are still learning? And so that's a great question, because back in the day, they like basically a part of the medical school curriculum. It was basically even teaching like racial inferiority, and like it was describing blacks in a way that was much inferior to other races, and that type of knowledge was actually within the curriculum, and it was being passed down, and that knowledge was given from generation to generation. And I think the answer to this question is we just need to be aware of this. We just need to be aware that this happens, and just to be, and just like, continue to do your own research. And if you know that these facts may not be evidence based, then that's half the battle right there. And just knowing that and just being aware of that and continuing to spread that awareness is a good first step in that.
Yeah, I mean, I agree with you, Chris. I think what's also important is if you also just bring it up to our professors and administration, just take it a step further.
I think speaking up is so important, because you don't know how far that can take, and so many people may be unaware that they're falling into this trap that has been laid down systemically for them. So if even one person speaks up and asks the appropriate people, hey, what's going on, or I feel this is incorrect, it may really help in the coming future.
Yeah, we're going to get more into that, deeper into that, even during our call to action section. Chronic illnesses.
Yeah, thank you. So what we're going to move on a little bit. We're going to shift from history into something that's something that doctors have to deal with every day, and something that we as future doctors will be dealing with every day. So what I mean is we will focus on a little bit of cardiovascular health and diabetes, as these are very common conditions, like I said. So heart disease is the leading cause of death in the United States, and the risk of heart disease actually does differ by race and ethnicity, where African Americans are actually 30% more likely to die from heart disease, twice as likely to have a stroke. There's higher rates of heart failure and higher functional impairments and higher deaths from acute coronary syndrome in African Americans. There was actually a really interesting study that I found. It's basically a surveillance study, so it was done from 1968 to 2015, that looked at data in the deaths of adults in the United States due to cardiovascular diseases. And their findings was that there was an overall decrease in deaths due to these cardiovascular diseases in all populations, regardless of race. However, there was actually something interesting, that there was variations in the magnitude of decrease by race. So what I mean by that is that there was a greater decrease of the average deaths per year in whites compared to blacks. And what was even more interesting is at the start of the study, so this is basically about a study of 45 or more years. So basically they just took data for all these years, and they found that at the beginning of this, there was a steady decline in deaths due to heart disease in both races. However, at around 1970s, the deaths in the white population continued to decrease, while in blacks it plateaued. So using data for surveillance of health between races will help policymakers and physicians to reduce health disparities. And although there is an overall decrease and improvement in this, there's obviously still things that need to be done. And these these studies shed light into this, because we may argue and say, oh, well, there is this general decrease. But if you really, really look at it, there is that racism that is tied to this, and we need to be aware of that and can't forget it. So as the other panelists have mentioned and made some excellent points regarding racism and inequality in healthcare, we also need to be careful to not fall prey to biased studies and misinformation that's out there, right? As future doctors, we do need to rely on facts and good science. So one such example is the slavery hypertension hypothesis that I actually only learned about in this research and through my classmate Rhea. Can you tell us a little bit more about this actually?
Yes, absolutely. The slavery hypertension hypothesis is something I read about a few weeks ago when I was writing my article. This hypothesis argues that African Americans have evolved to inherit genes that favor sodium retention to enable them to survive in the dry climate of Africa, but may cause them to develop hypertension when they migrate and start to consume more salt in their diet. However, it seems like this genetic explanation for cardiovascular health disparities in the Black community stems from a racist ideology.
Yeah, I mean, I absolutely do agree with you that this theory basically claims that there's higher sodium levels in African Americans, which is why they're more likely to develop hypertension than their white counterparts. However, a lot of pathophysiological studies have shown that salt-resistant individuals retain just as much sodium as their salt-sensitive individuals, right? So moreover, as medical students, we know that it's not just sodium levels that contribute to hypertension and developing high blood pressure.
Yes, even today, credible institutions such as the American Heart Association and CDC state on their website that higher rates of hypertension may be seen in African Americans due to their genetic makeup. But it doesn't make sense to use race as a risk factor to explain these health disparities because race is a social and political construct, not a biological one.
Yeah, I mean, I think that's definitely a good point that you bring up. And there is a study that kind of basically, backs up that idea. And this study is another longitudinal study where they evaluated the association of race with major adverse cardiac events, what they call MACE, where they looked at Blacks and white patients that had a baseline visit between 1987 and 1989. So between these 2 years, if you had a baseline visit, you were included in the study if you met other criteria, of course, but they were followed through year 2004 for the occurrences of these major cardiac events. And what they found was that compared to whites, Blacks had 1.24 times greater chance or hazard of these major cardiac events once they adjusted for age, gender, BMI, cigarette and alcohol use, educational, marital status, and aspirin use. So a lot of these social factors that we blame it on, they adjusted for this and they found that there is a difference based on race. However, what's actually even more interesting, that may seem a little counterintuitive, but it's actually not if you really think about it. So when they adjusted for high cholesterol, diabetes, and hypertension, they found no significant association of major cardiac events because of race, right? So what this suggests is that the comorbidities, which is cholesterol, diabetes, and hypertension, actually contribute more to these cardiac events. However, these comorbidities do occur more likely in the African American communities because of this institutional racism that's in place. So future medical interventions should focus on lifestyle and health management that can mitigate the development of race by working towards these, by mitigating the comorbidities, right? So some of the risk factors or these comorbidities that I'm talking about in African Americans, just to throw some stats there, is that they're 40% more likely to have high blood pressure. There's higher rates of obesity and twice as likely to be diagnosed with diabetes. So all of these will contribute to these major cardiac events. So taking into account this data, we need to have a broad viewpoint when studying this data and health in general, especially when it comes to race, as we may miss important information. So Rhea, why don't you tell us a little bit more about diabetes, please?
Sure, let's discuss diabetes. This topic is very personal to me as I was diagnosed with type 1 diabetes 13 years ago, and I can't remember a day where I haven't woken up, had my breakfast, and injected myself with insulin. As you mentioned, African American adults are twice as likely than non-Hispanic white adults to be diagnosed with diabetes. They are also 3.2 times more likely to be hospitalized due to complications arising from uncontrolled sugar levels, and 2.3 times more likely to be diagnosed with diabetic foot disease, leading to lower limb amputations. Systemic racism indirectly increases one's risk of disease by limiting access to quality healthcare and resources such as healthy food or even a safe place to exercise. But racism may also directly increase one's risk for diabetes by acting as a biological stressor and predisposing affected populations to poor glycemic control and obesity, which can lead to long-term complications such as neuropathy. So could racism be the reason why African Americans are diagnosed with diabetes at a much higher rate than their white counterparts? I decided to dig deeper. What I found was quite surprising. A qualitative study about African American women with diabetes found that experiencing racism caused changes in mood, emotion, behavior, glycemic index, and their overall cardiovascular health. From a medical standpoint, these stressors experienced by the African American community may affect glycemic control directly through increasing cortisol levels, which is a stress hormone that causes an increase in blood sugar levels and may lead to insulin resistance. However, I feel like the problem is much more deep-rooted.
Yeah, I mean, just to kind of reinforce that idea very quickly, I want to point another large prospective study where they looked at African American women and they studied perceived racism and the incidence of diabetes, right? So it's a different study. They essentially found the same thing, and they found that there was a high with a higher score of perceived racism, there was a higher incidence of type 2 diabetes. And you can tell us a little bit more, Rhea. I know we're a little bit short on.
Yes. Another study I found that was done in 2018 showed that African Americans perceived that socioeconomic factors such as poverty due to past slavery and racial discrimination by healthcare providers could contribute to developing diabetes. This is because they believe that poverty
I think it's just background noise. Can someone please mute their mic?
Please mute your microphones.
Sorry. This is because they believe that poverty influenced African Americans' unhealthy eating habits, which led to diabetes among their ancestors and their development of the disease since it was genetic. These participants also felt that there was provider ill intention. Due to ongoing misdiagnosis and faulty treatment, mistrust towards medical providers has led the community towards perceiving their doctors as doing more harm than good. The lack of education on proper lifestyle changes and management of the condition was done on purpose, as doctors withheld important information about diabetes due to racial discrimination. Moreover, comorbidities such as diabetes are the leading cause of cardiovascular diseases, as Ola was saying. Therefore, if diabetes is mistreated or misdiagnosed, us as future healthcare providers may contribute to the increased risk of developing cardiac disease in the African American community.
Yeah, and just to sort of wrap up our topic, the perception among the community on controlling diabetes based on coping mechanisms results from lack of resources, as Rhea was saying, faulty information and mistrust in the medical system. This may lead to denial of the disease. So one major conclusion that we found during our research is that comorbidities, as I mentioned before, they do play a huge role in patient outcomes. These comorbidities do disproportionately affect African Americans. So this then leads us to a downward spiral, because then there's other diseases that stem from these comorbidities, right? So after hearing a lot of important statistics so far with the health system in regards to race, as future physicians, we should try to make sure and change these statistics for future generations. We will discuss more possible action plans at the end of the talk, and thought we, as a team, we came up with some ideas that we can implement and help shape a better future for everyone.
Yeah, let's answer some of the questions we received through the Google Forms. I'm going to read the question out loud. Food plays a large role in cultural identity as well as a form of comfort for many communities. However, carb-rich diets lead to many chronic diseases. How should physicians address cultural beliefs when consulting chronic diseases? Yeah, this is a very thoughtful question. And I feel like as future physicians, it is important to understand the impact of culture is significant in medicine, and it influences lifestyle habits such as eating, exercising, which can then contribute to an individual's overall health. And for us as doctors, it is also important to not make assumptions about cultures that we are unfamiliar with, and instead learn about our patients' cultural beliefs. We must consider our patients as a whole rather than a list of symptoms that we need to treat. If we are talking about diabetes specifically, I would start off by taking a detailed history and asking my patients whether they are aware of the common risk factors for diabetes. I would then go on to ask them about their cultural foods and food that they enjoy having. I would try to suggest some low glycemic alternatives that they could include in their traditional foods so that they can still follow their cultural norms. And then I would go on to advise them on how to better manage their diabetes. I think, as mentioned before, for patients to comply with our recommendations as physicians, it is necessary for us to build a high level of trust with our patients.
Yeah, I think that's a great point. Thank you for those points, Rhea, and those recommendations that we should keep in mind. There was another question that I do have, but I will leave it so we move on to the next topic because we're a little bit tight on time. If there is time at the very end, I can come back to this question.
Thank you all so much for that. My name is Janae O'Gwyn again. So I'm going to be starting the discussion on maternal and child health. And it's a very important topic that we must discuss, not only for me as an African-American woman, but as someone who dedicated a whole degree to studying this. And in addition, we know that maternal and child health continues to be an area of improvement that can be had in our healthcare system, especially in regards to African-American women. And a lot of people don't really think about it like this, but the way that I like to see it is maternal health is the foundation for a good family health in general, because when we have healthy moms, we have healthy children, and we have healthy spouses. So it runs, very deep. And so it's something that really needs to be taken more seriously. In addition to that, we know African Americans are 3.8 times more likely to die due to complications of pregnancy. And we don't want to continue to see this disparity grow. We would like to see it decrease. And it's the fact that it's disproportionately affecting African-American women is a nod to what we've already been talking about, but the structural racism that's been ingrained in not only our country, but that's trickled down to our healthcare system. It's also important to mention that infant mortality amongst African-American mothers is 2.3 times the rate of compared to white mothers. So we really want to think about, what that means and how we can impact that as future physicians. And so it's not enough to hear about it. We just have to figure out ways that we want to actually impact it. So also we wanted to get into the discussion about a few other topics, because also, even though I'm saying African-American mothers, there's also a lot of issues that are affecting Latin American mothers as well. So we want to keep that in mind when we're thinking about this. And a lot of studies have shown that racism amongst, or how women are perceiving that their doctor is perceiving them, which they usually just title as racism, is affecting their ability to receive the proper care that they deserve. Okay, so Radhika, I wanted to get a little bit deeper into some of the things that we can do while women are pregnant and get into the prenatal care aspect that we had been discussing previously.
Yeah, so a lot of what Janae was just saying was highlighting how at the basis pregnancy is so important. How you get through a pregnancy is so important. And that leads us to why proper prenatal care is crucial. And prenatal care at a fundamental level is so formative for the community because, like she said, the woman's state of mind and state of health during pregnancy is extremely influential on the fetus's future as a fully functioning person. There are many studies that show this, and we even learn it in medical school curriculum that conception, pregnancy, and post-delivery are a critical period for forming a healthy human. And so preserving and putting proper care into a woman's pregnancy is of the utmost importance to create a new generation of healthy children. And this is why we look at racism to be at a systemic level, because it comes from the deepest roots, and actions during pregnancy do lay down the groundwork for a brighter future. So diving into prenatal care a little bit, it is recommended that women begin prenatal care immediately after awareness of pregnancy and then are regular with their checkups. And babies of mothers who do not get prenatal care are 3 times more likely to have low birth weight and 5 times more likely to die than those born to mothers who do attend regular prenatal care visits. And racial and socioeconomic disparities become even more prominent in regards to timing of entry of prenatal care. So when in the pregnancy do people start receiving prenatal care? And despite numerous programs that have been set up by the US Department of Health and Human Services, there still hasn't been enough in terms of getting women to enter prenatal care at an appropriate time. And so unfortunately, Black women belong to some of the most vulnerable minority populations in the US. And as Janae mentioned, these populations are more prone to infant and or maternal mortality, even including neural tube defects, preterm birth, gestational diabetes. These are all, many of them are largely attributed to social circumstances, shortfalls in medical care, environmental exposures. So what I mean by social circumstances, and we're also going to dive into this a little bit, the environment that the expecting mother has to endure during pregnancy there is a larger disparity that Black women typically face. They may face, they do face racism. They may face poverty, having multiple children at home, having to skip meals to provide for the other children at home, having unstable partners, having under-involved or over-involved family members. The list goes on. But ultimately, the point that I'm making here is that these stressors at home, scientifically, they raise corticotropin-releasing hormone, which we learn in our med school curriculum. And that in turn raises cortisol levels, and that induces preterm labor. And then you have premature children being born. And this is all an ongoing cycle that keeps occurring, and it has to stop somewhere. And so because of environmental stressors, premature babies are being born, and that puts them at more risk for error. And because the root of this issue is systemic, it is important that policymakers and healthcare providers take responsibility for these significant disparities in maternal care. So and disparities in maternal care and maternal morbidity are not only issues of risk and race. Their structural racism in healthcare is perpetuated by unjust policies that we currently have into play. And those are the larger causal factor for the high maternal morbidity that we see in Black women. And it's very easy to put the blame of these issues on technology, like, where lack of resources or technology is emphasized as means to better health. But it's not always technology or lack of resources problem. We need to look within ourselves. In fostering a better relationship with the patients, building that trust, like Vaishnavi was talking about earlier, building that trust with your patient is really important. And for pregnant women, that trust goes a long way. They feel comfortable to talk to you. You feel comfortable to talk to them. That leads to better communication, getting more information out of them so you can help them in the best way possible. And so this will tie into our call of action, like what do we need to do as future physicians to prepare ourselves for change? And so we will be going through that shortly. But really quick, just a really quick background on prenatal care. There's very quick, 5 prenatal care methods currently into play. There's the most obvious one, the one-on-one care with your physician. The other ones are group prenatal care, home visitations, mobile vans, or mHealth, like through apps on smartphones. But I'm going to focus a little bit more on group prenatal care because it has shown to be the most successful and the most diverse. So it has reduced preterm birth rates by as much as 33% when participants are consistent. And that leads to longer gestation time and higher birth weight. Patients that have received prenatal care in the group setting, they experience self-advocacy, community support and friendships, free discussion, learning. Those are really beneficial things in the long way and in the long run. And some of those things are things you can't get during a one-on-one appointment with your doctor. And so it tends to build an environment with camaraderie, and that can be really positive during a pregnancy. And so there is a current program called Centering Pregnancy, and Janae has direct experience with centering pregnancy, which she's going to probably plug in a little bit. But basically, this program offers 12 women at a time to sit in a room and learn about things like prenatal nutrition, common discomforts of pregnancy that they may experience, relaxation, the process of labor, what to expect, even up to like family and parenting, tips on parenting and what the birth experience is going to be like, decisions of pregnancy, developing a birth plan, infant feeding. There's so many things, new baby care, whether to have more children or not. Those are all discussed in the group prenatal setting. And it's so versatile, especially for expecting mothers who have lower education levels. They don't just get thrown a pamphlet and have to read it at home. And instead, it's more of an interactive experience with their peers, other pregnant women.
Yeah, and so it's got a really fun actually interactive workbook where they actually are able to go through, and it's like more, it has words, but it's more picture oriented. And I do have personal experience with women of color using centering pregnancy. And it's actually been shown to be very effective. I also wanted to plug in a little bit about the instrumental support aspect that it provides, and a lot of things that women feel like they wouldn't have been able to do on their own, they're encouraged and empowered to do. For example, take on breastfeeding behaviors, which is something that African American women also don't do as much. And it's important because it also impacts, when you want to talk about child's health, there's a lot of protective factors that can be gained from breastfeeding by the child, whether it's their immune systems, or if we talk about childhood obesity, that being a protective factor. So that's very important when we want to talk about these types of things. Also, women find that they're getting more time with their doctor because it is a little bit of a longer session, because they're able to because they're having more women. And so that's another positive benefit. And I know something else we also discussed in regards to this is incorporating like a social aspect. So to connect mothers with programs that will be not only helpful while they're pregnant, but also after they're pregnant, to be able to get the resources that they need for themselves and their mothers. And I think that this is a really big nod at collaboration in healthcare. So that means like including your nurses, including your nurse practitioners, including those social workers, to be able to really ensure that your patients are getting the services that they need, because it's not enough to tell them. I think that as physicians, we should be taking it a step further and putting them into contact with people who actually have the power to connect them to those resources. So we did have a couple of questions that we wanted to address. So one of the questions was asked about that several of the environmental stressors that we have mentioned are experienced by many expecting mothers, and they wanted us to elaborate on how and what factors or aspects of racism specifically lead to more significant stressors in African American women. And it is true, right? Being pregnancy is stressful, like on the body, just on a physiological level. But for African American women, it's like somebody who starts here when they're pregnant and somebody who starts here, right? So it's like, if you don't have the access to the resources, if you're fatigued and you don't have a job that is going to be understanding, a lot of mothers will be in positions, for example, if you're educated, you're more likely to have an understanding work environment that is, I guess, less demanding in a lot of ways. Then that can be a factor that could be affecting how these women are experiencing these stressors. Also, I would probably nod at the fact of education, right? We know that African American women, there's sometimes disparities in that, so that can make things harder. Depending on what your financial circumstances are, if you're even able to get to where you need to go when you need to get there, because being pregnant is another obligation. You have more appointments to go to, you have medications, you have things you can and can't eat, and if you don't have a grocery store within access, that's another stressor that's been created for you that might not have been created for someone who wasn't of color, because they have a grocery store maybe within walking distance and you don't have even a grocery store within driving distance. So those are a few things that I think are important to highlight. And so I'm hoping that I answered that person's question and gave them a little bit more clarity on that.
Another question we got in, what role does mental illness and experiences that harm mental health and well-being have on patient outcomes? This is such a broad concept. Mental health is a very broad concept. We could probably hold an entire session on just mental health. But in the context of what we're talking about at the moment, and I know there's a comment on this also, external and environmental stressors affect the pregnancy drastically. So when there is stress, that often causes mental illnesses, then affects the pregnancy. And a couple other things, just quick plugins about mental health that we've kind of discussed as a group through this process. There's a lot of stigma behind mental health. And that ties in a lot with culture, because not all cultures are willing to listen to issues regarding mental health or seek therapy. Also, there is a huge therapy desert in terms of like lack of insurance coverage for therapy appointments. Prior to coming to medical school, I lived in San Francisco for a few years, and San Francisco is known to be a therapist desert. The therapists are everywhere, but there are barely any that take insurance. I think there are like one or two in the whole city that take health insurance. And so out of pocket becomes then too expensive, and it leads the person to put a monetary value on their mental health, which isn't fair to anybody, because again, this is all cyclical and all systemic, And so the kinds of policies that are in play right now sort of continue to enable trends, which is what we're seeing right now. And thankfully, we are all calling that out. People are starting to become more vocal and calling it out.
I think Radhika, it's also a fair point to see that like we don't see many women of color or even men of color up at the top as physicians, as therapists to help each other out. Like I feel so many times if we're looking for a therapist, we want to see someone to relate to just on a cultural level, on a language level, on so many levels. So if we don't see people like us who are offering to help us out, that may be a deterring factor for me trying to attend therapy because I don't know who I can talk to. Will they really understand my problems?
Yeah, and that ties into a lot like what we've been talking about making sure that the career itself, the entire health career, gets diversified.
Exactly.
Yeah. So we have some great questions that have come in that are more general questions. And how we have decided to format our call to action section of this talk is to actually answer these questions, because the answers themselves are going to inadvertently talk about what we plan to do and what we promote our peers to do. So the first question that we've gotten in, what is implicit bias? What's an example of implicit bias that you may have experienced, witnessed, or heard about? And what role does implicit bias play in medicine? How vulnerable and how are vulnerable populations impacted?
Yeah, so I'll take this one. So with implicit bias, it refers to attitudes or stereotypes that you're unaware of that affect your actions and how you govern yourself. So a lot of the times it's you don't know that you hold this bias, right? So when we talk about impacting said bias, we have to first learn that we have it. And there are free tests available online where you can test. It's called an implicit bias test. You can Google it and you can take it. So first being aware that you have this implicit bias and making sure that you're actively working against it. So when you ask like, how does it impact healthcare? Well, if I feel like, for example, you have some type of illness and I'm like, I want to prescribe this person with this medicine, but I see her and maybe you have this opinion that Black people don't take their medicine. You're like, well, I'm not going to prescribe it to her because she's not going to take it anyway. And like, you didn't maybe think that consciously, right? But like, you just have decided not to prescribe something that a patient needs. And so I think, like I've just said, educating yourself on it, addressing it, and unlearning the bias is very important. And like, it's like a thing where it's like, nobody wants to feel like I'm racist. And you may not be racist, but you have to also sometimes address the things that like, even before you were aware that were being ingrained in you. And so you have to have that knowingness that it exists, and also being aware of some of the health disparities that we've discussed and knowing those things so that you're aware when you're seeing this type of patient, other things or considerations that should be had in regards to these patients.
And just real quick, I agree with you as far as we need to self-identify with these implicit biases, right? But I would think it'd be even beneficial if more medical curriculums added this to try and make physicians aware or future physicians aware of the implicit biases, because it starts from there, right? Because they even add certain implicit biases in the curriculum. So I think we have to look within ourselves as a whole system and kind of hit the root of the problem. We can do the self-study, right? We can do all the self-education, but I think it should also not be taught to us.
I agree.
Yeah, just a quick point to add to that. I previously had a job that was in the ER on the border of Oakland and Berkeley. I think everyone knows what the stigma around Oakland is like. It's a pretty tough area. And there were a lot of homeless people that were coming through the ER. And it was kind of a wake-up call to me that there are implicit biases amongst physicians. It was the ER doctors, like they're fantastic doctors. Obviously, they do their job really well. But hearing them talk in the room, in the back room, with, they have biases about homeless people. Those are the kinds of things that really stuck with me, that, okay, it's going to be important that when any patient that I see, that I come into that appointment or that visit with them, and I ask them the same questions that I would ask anybody else, making sure that there's consistency so that they feel like they are treated fairly. even though we as future physicians, we know that biologically some things may differ, like African Americans get more sickle cell anemia, right? Those kinds of things, we know that from our knowledge that we have learned in medical school. But to build that relationship with the patients, it's important that they see that we are asking them the same questions that we would ask anybody else. And so that kind of relates to implicit bias and making sure that everybody is treated fairly and equally. Does anybody else have anything to add on that? We have a few more questions to address.
No, you guys did a great job.
I am sorry, because there was another question that tied directly into this in regards to educating and implicit bias, because someone asked about how do they educate their non-people of color family members on racism, and they wanted us to maybe, like, I guess, address that or give some advice. So that's definitely a hard one, right? But I think it's kind of like silence is agreement. And it doesn't mean that you have to raise your hands up and yell, but you just make sure that people at least become uncomfortable in your family talking in that regard around you in regards to the topic, because they're aware of how you feel about it. Like, that's like a thing. Because it's like people are not gonna, they're gonna like, oh, I'm tired of hearing it. And eventually, like, to be honest, I think people will come around, but I think if you just keep pressing the issue and correcting where correction needs to be had, that's the first step. You can't change people, right? You can lead a horse to water, but you can't make them drink it. But if you continue to show that I'm not gonna like participate, or I'm not going to help, reinforce this idea that you all have, I think that that's important, because as your family member, you have to remember they're more inclined to listen to you as well, because they care about you. And there's, obviously something, you're going out into this world, you're becoming a physician, and there's going to be certain things that you're going to be exposed to that they're not going to have the privilege of being exposed to. So I think that you should keep those things in mind in regards to addressing your family members who do have those ideals.
Yes, I feel like I can relate to that question, but I think it is important to highlight that we can choose to ignore to learn about racism. We can choose to be oblivious to it and pretend that it doesn't exist. However, our Black friends, our Black patients, and the Black community cannot choose to not experience racism. So I think that having these conversations with your family members, no matter how uncomfortable they may be, I think you still need to continue having them and educating them about it, because like Jenny said, as your family members, they are more likely to listen to you. Yeah, that's what I wanted to add.
Yeah. The last comment that just came in is fantastic, and there are quite a few teams in school already that are working with SGU and SGA on trying to get the medical school curriculum changed. But the last statement that was written here that I'm referring to, going off that, many times in class, faculty will make statements like Black people experience higher rates of blank condition, but no context is provided. How can we as students address this right away, specifically with everything on Zoom right now, with hundreds logged in and not much opportunity to ask questions during class? Like, if a teacher says something like that, how can we address that and ask for further context so that students don't leave the lecture only adding to their bias? That is such a good point. And we actually got a couple more questions similar to that. Another one, where can I learn how to diagnose symptoms for darker skin tones when we were only taught how to diagnose them on lighter skin tones? And actually, there was an article that the New England Journal of Medicine just posted like a couple days ago. I know a lot of you guys might have seen it already, but it's a commentary written by a Black first-year medical student. And she was talking about her experience of going through mandatory CPR and how the mannequins for mandatory CPR are all male bodies. And she states that she left a 2-hour course without having any knowledge on nuances of performing CPR on patients with breasts, or the precautions that you should consider with pregnant women. And because of because of this issue, women are less likely than men to receive bystander CPR because of fears regarding inappropriate touching or potentials of potential accusations of sexual assault. The other thing she mentioned in this article was Borrelia burgdorferi, Lyme disease, from ticks, right? You know, we know from school that it's like a red spot with a ring, like rings around it, right? And it shows up as red ring. And you can see that on lighter skinned individuals. You can't see that on darker skinned individuals. And so she was actually mentioning, and we don't know what medical school she comes from, but she was mentioning that in her med school, she asked the question to the professor, like, hey, how do we see this in darker skinned individuals? And it seemed like the professor didn't know the answer to that question. And so that's kind of like, that also highlights like curriculum, education, and education to the physicians, not just patient education, but physician education needs to improve. Like continuing education, you know, they have to get retested every, I don't know how many years, I think like every 10 years or something, they have to go and sit for a test. Those are the kinds of things that should be taught in continuing education. And so this can lead to huge consequences of misdiagnosis or even missing a diagnosis altogether. And so we got another question about kind of on the similar lines of what to do at a school level. And this is a little bit of a sensitive one, but what are some avenues and options that we have if we are concerned that one of our peers may be violating the physician code of ethics in the form of racism? It seems dangerous to just continue to let these students progress to clinicals, but I do not know if SGU will do anything about such things. Unfortunately, we cannot speak for the school because we're a student-led initiative. We're kind of in the same boat as you guys are, you know? But because we got this question about 10 days ago, we did talk to our student government to, just like there's an anonymous reporting of sexual assault, the SGA, our student government, is going to try to work with SGU to create some sort of anonymous reporting for racism, because it is an issue and it is concerning that those people would be moving on to clinicals because that is a health hazard. So we really appreciate the person that brought that up, and it has been addressed with SGA already, just letting you guys know.
I agree. And I think we also mentioned the idea of, you know, spreading that idea of empowering students, you know, to speak up if you feel empowered to do so. I think a lot of times people will do it and then they think they can, oh, everybody's okay with it if you don't speak out with it, and then that behavior continues. That's almost a way of reinforcing it. So if you feel empowered to speak out in a way that is professional amongst your peers, then I would say that that would be a good avenue to go as well. But also just knowing that you have that anonymous resource to go to as well is good.
Yeah, and just to add on to that, I think something that's very important in healthcare today is accountability. You know, we want to all hold each other accountable for certain things because, you know, we're all, you know, future physicians and we all want to give the best possible care to our patients. And so, like, if we don't hold each other accountable, then, you know, we're just a part of the problem as well. So I just wanted to say that.
I agree with Chris, and I feel like the first person we should hold accountable is ourselves. And this point was brought up a few times as I was reading through the chat box, that we need to constantly educate ourselves on like what's going on, the microaggressions we held, the implicit bias we may unknowingly hold, and how to like better ourselves each day. So like if we ourselves are not accountable, how can we point fingers to someone else? So I think it starts from within, and like Chris was saying, like you hold others accountable for the same thing as well.
Yeah, and what I've been noticing lately, especially with all the current events that are happening, there are a lot of misinformed people. I wouldn't go so far as to call them, you know, ignorant, because truly some people are just misinformed. And they need somebody to talk them through thought processes. And whatever we can do to plant those seeds can go a long way. If something that you say, one sentence that you say can resonate with them, and they can understand the thought process, so not being afraid. And we've talked about this as a group a lot also in the last few weeks, is that not being afraid to have uncomfortable conversations, because this conversation is uncomfortable, but getting ourselves to talk about something that's uncomfortable is the only way to make change. So if nobody has anything to add to that, we have another question. As physicians, we need to consider, what does the disease mean to the patient? The patient's perception towards disease will greatly impact his or her compliance and control.
I can take that, actually. I think that's a great question. So I feel like this question sort of piggybacks on like everything that you guys have pointed out and made some excellent points, because this question is more looking at the physician rather than looking at society and what we can do. So I think that as future physicians, we need to take the step ahead of the patient and understand how they feel, right? So even if we do not look like them, we're not from the same culture as them, we do need to consider those as physicians. The role of a healthcare professional is not to tell someone what to do, it's really to provide them options. And again, you can't choose to say, well, this person looks like this, so I'm going to give them these certain options, and someone else, I'm going to give them different options. Everyone should be treated equally. So you have to work with your patient to come up with the best plan, taking into consideration the culture that we spoke about, their background, their skin color, all of these things. And we have to ask them questions like, are you willing to take these medications? This is what your treatment plan is. Are you able to do this? And if they say that they cannot, and if you address this up front, you won't have these effects and these terrible outcomes years down the line, because you've already addressed it up front. So it's not going to be a surprise to you that the patient won't be taking their meds, right? Because they told you off the bat, it's hard for me because of X, Y, and Z. So, and if that's the case, then that's a perfect opportunity for you to help change these statistics as a future physician, right? Because then you can come up with different plans. You can understand where this patient is coming from. And sometimes culture does play a role into this. There's that, culture shame where, Radhika, you brought up about, mental illness, right? And even food, like some foods are known to cause certain diseases, and it is known that more cultures eat this versus others, and then those cultures do see this incidence increase versus other cultures, right? So what we can do in those cases is understand. Again, the key, idea here is to communicate and understand and not judge, because as physicians, we shouldn't be judging anyone based on anything that's external. And then we can work with them and say, okay, well, you know what, let's take it, step by step. And this way, the person, your patient won't feel shame, and they will actually trust you more. And they will come with you with other issues, and you can help them more. Maybe they'll come with you with something that maybe you can't directly help them, but you can direct them to a physician that could, versus if they just keep it internal, again, this thing can bottle up and manifest into some other disease. So basically what the main idea here is to develop a patient-centered care plan when we are out there in the force, and as future physicians, or if there's any physicians on the line, to just keep a patient-centered care approach, and to take their lifestyle and feelings and cultural views into account.
Yeah, and remaining humble as a physician. The patients are ultimately one of our we have an RN on our research team, Cynthia, and she said the patients are employing us. We have to be very grateful for that they have chosen us as a physician. And again, like Ola said, it's important to provide the patient with many different types of plans for change. We can't just assume that the patient can afford the kind of lifestyle that we're recommending to them. And as we all know, like, healthy food is more expensive than junk food. And so, and and this kind of goes back to what we were talking about earlier with food deserts. Places, a lot of cities, a lot of towns in the country, there are 50, 100 miles between grocery stores that have fresh produce. So if a doctor gives a recommendation of eating more vegetables, like where do they get their vegetables from? So making sure that we are, aware and competent in that.
Yeah, I think acknowledgement goes a long way for a physician to acknowledge the cultural background that a patient comes in with and what like setbacks they may have as a result, and for them to come up with like a compromise that like, this is what I recommend and this is how much I know you can accomplish. So we'll find something in between that would work out the best for your health.
Yeah. So the last question that we have is, what are some resources you can recommend for your white allies to continue to grow in our understanding and activism and overcome ignorance? So we already had some recommendations in the chat, which is fantastic. We had Medical Apartheid. We had some books, Medical Apartheid, Immortal Life of Henrietta Lacks, 40 Years of Medical Racism. We had a couple of book recommendations in the chat thread. We do plan on, when we publish all of the unanswered questions, by the way, thank you guys so much for participating. Everything that hasn't been addressed, we will be addressing it and publishing a Q&A type of sheet with recommendations, book recommendations, documentaries, things like that. But in general, activism runs deeper. It's activism outside of medicine runs deeper than just reading books or watching Netflix. Going farther than the bare minimum, making sure we are being proactive in educating ourselves, not just sitting idly and waiting to be educated, because, as much as all of us are trying to get medical school curricula changed, it's not like a given that it's going to be changed right away while we're in med school. We're only in pre-clinicals for 2 years, right? Most of us are going to be out of our pre-clinicals in, the next year. And so even past that, what can we do? We can continue to educate ourselves, be open to reading, be open to listening, have our ears opened all the time, have friends of diversity, learn from our friends. That's what our friends are for. That's what our peers and colleagues are for, is to learn. And I feel like myself, at least I have learned so much in the past few months, and I have learned so much from, the other speakers and our research team. And I just want to make some acknowledgements. If nobody else has anything to add, I want to make some acknowledgements. Our research team has been fantastic. We've been meeting a couple times a week for the past few weeks. We have Anjali Thoda, who is, she has been moderating our questions and posting them into the chat thread. Hugo Gonzalez, he's currently a term 4, almost done. In 2 more days, he'll be done with term 4. Jessica Zavala, Cynthia Gutierrez, and Raga Kanakam. Thank you guys so much for, constantly just imparting information. It's been so great. You guys have, done a lot of the legwork for us. And yes, we are the speakers and we're delivering the information, but it's really been a group effort, which has been fantastic. And thank you so much to the SGU chapter of the Student National Medical Association, SNMA. Conrad, Chris, and Janae, thank you so much for being a part of our panel and really enhancing the information that we're delivering. If anybody else has anything to say. Did somebody say something?
Thanks for making us a part of this panel.
Yeah, thank you so much.
Yes, thank you.
Thank you guys for joining.
Thank you, everyone.
Thanks so much. Thank you to all our viewers. All the questions that are not addressed, we will be addressing them. But thank you so much for tuning in today. Hope you guys benefited from this.
Thank you, everyone.
Thank you.
Thank you.
And stay safe, everyone.
Thank you.
Thank you.